presentation. When I start to dig the history of the transposition, I found so many unknown, to me also interesting facts, and I would like to show today also. First time transposition was described by Danish anatomist Steno, who also described the tetralogy of Fallot. And first time the coronary arteries, the anatomy of coronary artery was described by Germans in 1922. Since then, passed many years until the first attempts were made to treat transposition surgically. This is the slide showing the first illustration of corrected transposition by Rokitansky, his famous book, The Defekte Scheidewand Herzens, published in 1875. And this is also illustration of his book showing the transposition with ventricle septum defect. Also in this book, Rokitansky, among other themes, proposes transposition theory of deviation of the atrial septum. And next, very important hallmarks in the transposition history was the proposed segmental analysis of the congenital heart disease by Richard van Praag and his co-workers. This is concept or this idea helped us to understand many complicated and complex form of the transposition, make correct the diagnosis before the surgery. Now what about the surgery? This is the flow chart of the history of the surgery for transposition. You see it started already in 1948, and there is many different methods were proposed, like the Braddock canal operation, arterial switch and pulmonary venous translocation operations, Raschke for the arterial switch operations, Rastelli, Bexley-Comte, master sending intraventricular repair and double switch, and I would like to go through all these operations. The first Walhalla-Braddock operation proposed and performed first time in 1948 by Alfred Braddock on Rollins Helen. This is the original illustration for the original publication from Helen about this operation. You know, this operation means that the atrial septum was resected through the special maneuver through the intra-atrial groove, and they helped the patients to have a better mixing of arterial venous blood, and they survived for the next step of the surgery. Interesting that this idea of operation was emerged very accidentally when Vivian Thomas, who was the medical assistant to Dr. Blaylock, and he wrote a very interesting book about his experience with Dr. Blaylock, and he incidentally created an atrial septum defect during the experiment to special clamp, which was decided to perform this so-called pulmonary venous translocation. Sometimes these incidental errors help to develop new operations, as you can see here. And this is this operation they developed. This is the pulmonary vein translocation. They think that it was possible to translocate the pulmonary veins to the left atrium, and on this way to improve the arterial oxygenation. But this operation was performed in 9 patients without success. One patient died, and this patient, as I know, never performed later on. The next step was the so-called Buff's operation. Thomas Buff was a surgeon in the United States and developed so-called the inferior vena cava and pulmonary vein translocation. This means that the right pulmonary vein emptying in the right atrium was connected to the right atrium, and the inferior vena cava to the homograft or some kind of the conduit was connected to the left atrium, and this way the oxygenation was improved. He performed altogether and published in 1955, in 1960 this paper. He had done 38 operations with 90 survivals and with significant clinical improvement. It's interesting that many of these patients later on underwent successful atrial switch operation. Raschke developed his method to create the atrial septum defect. This is original picture of his first publication. This is so-called Raschke catheter, which is still used nowadays. It will be discussed today, the drawbacks and the new aspect of this intervention. But interesting, this operation saved many patients with transposition and gave them chance to operate it later on with the atrial switch operation. But I want to remind you that the first time so-called balloon catheter in congenital heart disease was used by the Barnauskas, who worked with the Viking Björk, and they used at that time in 1954 for sizing of atrial septal defect, because many patients operated at that time died after the operation because of high pulmonary hypertension. He tried to find at that time which patient is a good candidate for operation, which is not. And they closed the ASD with balloon and they measure pressure in the pulmonary artery with another catheter. And as you know, the sizing is still performing now, but for other reasons to sizing the ASD for the closure with the occluder. And this the flow chart from Rashkind, and you see the time before balloon arterial septostomy until the operation was performed is quite long, almost 1 year. And many patients died in this intermediate period because of the complication of the transposition. So the surgeons tried to find out another methods to treat the transposition, and some operations were developed, like Albert, Grich, Senning, and Massad operation. It was Albert in the United States who first time proposed so-called intra-arterial switch operation with some kind of the patch who was switched the venous pathway to the pulmonary ventricle and arterial pathway to the systemic ventricle. There's another variant of the Albert operation, the Grich operation. All these operations were proposed, performed, but unsuccessfully. The next step was so-called Senning operation. Senning worked very intensively on the closed methods to close the ASD at that time, and maybe he helped him to develop his ingenious Senning operation, the atrial switch operation. But the problem with the Senning operation was that initially the mortality was very high. It was almost 64%. But Quackebo in Brom in Netherlands, they reviewed the Senning operation through technical modification, and they resulted in considerable improvement in hospital survival. This is the 20 patients they operated. This is the original pictures from their publication. This is Professor Brom and Dr. Quackebo, who now works at, as I know, in New York. And they modified the Senning operation. They have an excellent result for that time with mortality about 10%. But Senning operation was difficult to perform. Many surgeons don't understand really how to do the Senning operation. They start to do the Massad operation, which was, seems to the surgeon was most easily to perform. And this is William Massad. This is his operation, very similar to Albert operation. And the when Massad was asked what is the difference between the Albert operation and his operation, he answered that my works, he is not. And this is maybe difference because basically this is the same operation. The many surgeons want to perform Massad operation. They went to the Toronto when Massad was the surgeon, but it was not possible to put all surgeons in the operating room to see how he did this operation. So he built up this big model of his Massad operation, and it was possible to see how to do the Massad operation on this model, big model. It's very good, interesting. The next step is Maggun. Maggun was the surgeon in Mayo Clinic, the maybe best surgeon at that time in the world. Yeah, he was a very excellent technical surgeon. I have a chance to see him. Unfortunately, he developed a very Parkinson's disease later on, was not able to operate, but the so-called master intraventricular repair, which can be performed in the older children with the so-called of the transposition variant of double outlet ventricle. And also I have to mention here operative Massad operation from Dr. Linda Smith, who worked in the Children's Hospital in Chicago. His idea was that in patients with high pulmonary hypertension, so-called Eisenmenger complex in the transposition, it's possible to do only arterial switch operation without closing the VSD, and on this way to improve arterial saturation. And this is the published in 1972. And this is the results of his experience. And you see that 15 years survival after this so-called palliative Massad operation was about 54%. I think it's very good results for this very complicated and difficult group of the patient. Several years ago, we published a paper about, with my colleagues from different countries, about the experience and history of arterial switch operation. And because the arterial switch operation is not performed very frequently today, only maybe in India and such countries, but there is still some place of this operation in the surgical repertoire. For example, for infants in transposition who came to the surgeon very late, for patients with pulmonary vascular disease, so-called the palliative arterial switch operation, and also this group of patients, the patients with so-called corrected transposition, whom this double switch operation is performed, and the arterial switch operation is a part of this double switch operation. And there is a group of the patients in whom impossible to perform arterial switch operation, the patients so-called isolated ventricle inversion. So you have to do here arterial switch operation. The arterial switch operation was very effective, very good results. Mortality was very low, but time showed that there is many problems later on. The baffle leak, systemic venous obstruction, pulmonary venous obstruction, it was shown already in previous presentations, so pulmonary stenosis, and so on. And also arrhythmias and sudden death. And this is some examples of delayed complications of arterial switch operation. You see here the functional right ventricle, inflow occlusions, and baffle leaks, and so on. So surgeons try to find other ways, but I would like to say this, the latest publication about late results of after scenic operation. The many patients are doing quite well. The main problem is the loss of sinus rhythmus. The 44% of patients have no sinus rhythmus after 20 years. And survival is quite good, 88%, but right ventricle ejection fraction, right ventricle function, is after 20 years, is more than 40% in 98% of the patients in transposition, but only in 58% of complex patients with complex transposition. Because of that, surgeons try to find how to help this patient with the failing right ventricle and the arrhythmias and so on. And Roger Mee was in Australia, who developed the concept of left ventricular retraining using bending of the pulmonary artery, followed by arterial switch operation in patient after mastered of the scenic operation with failed systemic ventricles. This is very difficult approach, and in his publication, this very rare publication, this is the Symposium held in the Bergamo in 1996 about the retraining. He remembering that his cardiologist asked him, do you think that you should bed all the mastered patient now? And me answered that you have to be crazy. This is a pretty difficult business. This is true, because you see the retraining of the anatomical left ventricle is not easy procedure of the operation, because the success is achieved usually in the 50% of patients, and in older patients sometimes it's not successful. So the next step was arterial switch operation. This is the history, short flow chart of arterial switch operation, beginning with Viking Bjork and ending with Richard Jonas with all steps. The master performed unsuccessfully arterial switch operation. I will show you later on. Jatin performed successful first arterial switch operation, two-stage for Magdier Coupe, Lecomte, so-called French maneuver. Lecomte maneuver, Castaneda started to perform routinely arterial switch operation in neonates, and Roger Mee described two-stage arterial switch, and Jonas described rapid arterial switch operation. It's interesting, I don't know if somebody knows that the Bjork proposed so-called supravalvular arterial switch operation for transposition in patients with the high pulmonary hypertension. He proposed this for patients like the palliative operation. Never performed, but it's an interesting idea. Maybe can be performed nowadays, I don't know, let's see. And this is the first clinical experience with the master. Master tried to switch the patients also, but he switched only one artery, the left coronary artery, right coronary artery he left in place. He operated 7 patients, all died. It was not successful, serious, but anyway, he published this is first paper about arterial switch operation. Also, Baffles, who performed this Baffles operation I showed you already, in 1962 published his experience with arterial switch operation. You see very nice pictures here, but he was unsuccessful. And already in the 1960s, it was recognized that for arterial switch operation, we need a very strong systemic ventricle. This illustration of the publication of that time with very interesting text. I will recommend to read this paper because there are so many interesting ideas on it. And this is the clinical arterial switch operation performed by Farouk Idris in Chicago. He was a brilliant surgeon, excellent surgeon, has many interesting ideas and operations. And you see he performed this arterial switch operation and patient died after the operation. Angiography was performed showing the open coronary anastomosis. But interesting is that the Idris at that time in 1961 made a very important conclusions. He concluded that left ventricle must be adequate to support systemic circulation. The young infants with the good developed ventricles and especially with VSD are probably the best candidate for arterial switch operation. And patient duct arteriosus must be divided and the pulmonary arteries must be completely mobilized. And this is the points we have used nowadays, a very important point for surgical success. So these people maybe were not so very successful in surgery, but they have very brilliant ideas. And this is the first successful operation for Adib Jaten in Brazil. And Jaten explained his attempt to do arterial switch operation with that he have done more than 2,000 coronary operations. And he was he thought that it's possible to do the same in the patient with transposition. And he operated one patient which died, and next operation was successful in a small infant with VSD. And this is the original publication from in Henry Ford Symposium, very important symposium for that time, 1975. And afterwards, he operated another 5th patient. He lost all this patient, and he stopped to do arterial switch operation, but and switched to perform the mastered operation. But this is the first successful arterial switch operation, which showed that it's possible to do this operation with very small infants. And of course, this is the complex operation. Every complex operation, they have complex problems later on. And this is the problems which we have with arterial switch operation. They are listed here with incidents collected from the literature. And Professor Gutenberg de Groot showed us the embryologic, maybe embryologic basis of this complication. I just want to show some of them. This is the pulmonary valve stenosis after the arterial switch operation, dilatation of the neo-aorta on the supraortic stenosis, or development of severe aortic incompetence in patient after arterial switch operation. You see the patient operated by us, and we published this case. And before arterial switch operation, this patient was operated at age 8 months with VSD on transposition and developed later on very severe aortic insufficiency. You see here with left ventricular dilatation. And during the operation, we tried to reconstruct this valve, but it was not successful. So we had to put here artificial valve. Now it's about 10 years after this operation. The patient is doing quite well. But as I know, there is more and more experience in patients with arterial switch operation because this valve, the pulmonary valve, behave it like after Ross operation in aortic position. So the next operation for pulmonary transposition with pulmonary stenosis, Rastelli operation, which in general correctly refers only to repair of transposition of VSD, not to the double outlet with the VSD, because when we do Rastelli type operation by outlet, this is a Rastelli type operation, but it's not Rastelli operation. And this is the first publication of Rastelli. This is Rastelli, who died very early in age of 37, but he did so many in cardiac surgery, and we know just the Rastelli classification for AV canal, and also the Rastelli work on the hemodynamics after the mitral valve replacement. And this is the Rastelli operation published first time. This is the experimental work in the Mayo Clinic Prosthetic. This journal exists anymore. And this is the Rastelli operation. He showed how to close VSD, and this is homograph put on the right ventricle and connecting the right ventricle to the pulmonary artery. This is the publication with the new approach to anatomic repair. It's interesting that Rastelli we published a paper about this. It's very connected to the sister of Rastelli, who gave us very interesting data about him. And after the publication, we get a letter from Mark Elliott, who wrote us, this is interesting, that Rastelli never had a permission in America to work as a surgeon. He had the only chance to work in the experimental laboratory. And when they want to go back to Italy, he had no support what his chief in Italy, and he wanted to stay in the United States. And this aspect still exists in the United States and maybe in other countries also. And the first successful operation was performed by Roger Wallace in the Mayo Clinic, and this patient was operated as 14 years boy with 2 previous bradycardic operations, and 20 years after 4 reoperations, he doing well, have children, is married, but it's very important that after first successful operation, he has 4 reoperations. So Rastelli operation is operation when we have not very good survival, about 60% up to 20 years. This is a big group of the patients analyzed in Mayo Clinic with early mortality at that time, 24%, and now about 5%. Follow-up 160 patients, 33% of late deaths, overall survival. And this is the problem with Rastelli operation, because you see here the freedom of reoperation is very low. After 70 years, it's about only 30%. This is the reason why some surgeons discuss what is better in some patients, what is better to do the Rastelli operation or to do the Fontana operation, because survival after 20 years in Fontana is about 85%. This is a point of discussion. Maybe will be discussed today also, but it's also option for some very complicated patients with very complicated operation. And the candidates for Rastelli operation, for example, for patients with straddling pulmonary valves, the atrial ventricular valves, or the patients with the remote VSDs, and so on and so on. I want to remind you that gives one way to do Rastelli type operation in patients with corrected transposition, for example, so-called atrial groove patch plasty. This is the operation proposed by Japanese surgeons. When you open, the right coronary artery in the correct transposition goes over the right ventricular outflow tract, so you cannot open the right ventricular outflow tract, and they put here the patch. Because of stenosis, they proposed to do an incision behind the right coronary artery this way, and they put a patch here. It's very interesting idea. I know that it was done already in Germany in St. Augustine, but I think this is the one option for some patient with corrected transposition. And there are some new developments in transposition surgery, like Bexley-Comte operation, Nycadov operation, double switch operation, and prophylactic pulmonary artery bending. I just remind you, this new operation sometimes they have to fulfill several criteria. This is very important. This is very essential that the value and safety of operation will be established before it's widely used in the patient. This is the statement of American College of Surgeons. It's not only about the transposition, that's about every new operation which we want to replace the old one. And new treatments are usually judged by their early results. Even the treatment is meant to be a long-term investment. That's very important, because we can have very low mortality, but after 5 years we have problems, we have a complication, we have to think, should we continue to do this operation or to do again the old one. So translocation operation, this was first Kreutzer, who first time used the pulmonary valve in other anatomic position when he performed an ingenious operation for the tricuspid atresia, who have used the native pulmonary valve to connect it to the atrium. And this is the illustration from his publication. Kreutzer was working in Argentina. When I prepared this presentation, I have no picture of Kreutzer, and so I have asked his son to send his picture. It's in the son of his picture at that time when he did this operation. So another is Beck's Lecomte anatomical correction. You know that Lecomte is a very innovative surgeon. He did many very new interesting operations. And he did his first operation of translocation. He translocated the pulmonary artery and the aorta in 3 months old with transposition, so pulmonary stenosis, subpulmonary stenosis with good pulmonary valve. You see this was successful and published in 1980. This is the first successfully performed so-called translocation operation, so-called also the Nycado operation. Very complicated operation for different type of the transposition with left ventricle outflow tract problems. The main problem is the conduit obstruction is still the problem like always, and we have not really long-term results. And afterwards, some other operations were developed, like pulmonary root translocation by Chiavarelli and pulmonary artery translocation by Lecomte again here, and double switch operation. The double switch operation is operation which is performed now more and more frequently by many surgeons. Interesting that Marc Delaval, when he published his paper about VSD closure in LTAG, in his discussion in the end, he first time discussed the possibility of double switch operation. It's very short part of this discussion, but he was the first who proposed this idea to do the double switch operation. And this double switch operation, well, for first time was performed by Ilbavi. I already showed his experience with switch. And this is the first illustration of double switch operation in 2 patients. In 31 years old and 38 years old patient with LTAG, pulmonary atresia, and LTAG and dextrocardia pulmonary stenosis, very difficult patients. He was successful. I told you already he was a brilliant surgeon. Yeah, everybody knows that Ilbavi was one of the best surgeons in the United States at that time. And this is the illustration. And also this is a variants of double switch operation. You see, it's very complicated operation. This very simple in patient with the VSD and the high pulmonary pressure and the correct transposition, but in patient with the pulmonary stenosis and so on, dextrocardia is quite complicated and includes part of the different operations. The Rastelli operation, Atrial switch operation, and arterial switch operation. And this operation, because it's so complicated, it accumulates all possible problems of all these 3 operations later on. And this is the late results of the double switch operation presented by Ilbavi, 12 patients, and he shows here that they have pacemaker in 1 patient, they have 1 death later on. They 10-year follow-up, 100% body arrhythmias in 4 patients, conduit respiration in 5 patients, tricuspid valve incompetence in 2 patients. And the latest development is early prophylactic artery, pulmonary artery bending in isolated congenital correct transposition, transposition of the great arteries by Pascal Boyer in Paris. 11 asymptomatic patients with transposition, 7 neonates, 4 infants. And you know that after the bending geometry is changing in patients with the L transposition. Some are doing quite well after that, and there is no need for the next step. They do the double switch operation maybe. And you see his results here. And 1 patient underwent the successful double switch operation after 7 years. I don't know how it's ethically possible to do this operation in asymptomatic patients, because we know there are some patients with correct transposition that are doing quite well, almost 50 years without any operation. And this is an indication of double switch operation. It's interesting that the person who developed with Ilbavi this double switch operation, he changed his opinion about the indication for double switch operation. And he's presented here, and he wrote that I think that if you have a patient with correct transposition pulmonary stenosis, it's unusual to have a problem with the tricuspid valve. So I reversed back to write the person who developed this operation. I revert back to simple closure of VSD and either conduit from left ventricle to the pulmonary artery or relief the stenosis, because I'm not sure that is really worthwhile doing this complicated operation, corrected transposition with pulmonary stenosis, because I think this outcome is similar. This is a point for discussion and for the criticism. So we can say that the patient who get the double switch operation are doing well all the time. And the question is double switch operation better than the classical repair? I don't know. I have no answer of this, but I will show you what the people are thinking about it. This is the results. And we have to always think about the long term, and we have no definition what is the long term, yeah? Because the long term for the newborn child who is 2 weeks old, 10 years is not long term, because if he dies after long term, this is not good long term. And the long term of the 60 years old person, and he lives 10 years after the operation, is a good result. So we have not still a definition, but I think that people have some answer of this. And you see here, this is the longest series of 127 patients operated conventionally for corrected transposition. Survival 74% at 10 years, and almost 50% 20 years after the normal conventional repair. And difference in survival, they concluded, is not evident until 10 years follow-up has been elapsed. So it means that we have to wait 10 years at least to see what is the really long-term results. And Hraska, who worked at the time in Boston, also published this experience with the conventional repair, and they show that after 15 years, the survival after classical repair is 61%. It's almost similar to the experience from Toronto. But what happens about double switch operation? This is the latest publication of double switch operation from the Great Britain. From Brown, you know, he's very successful with double switch operation. He performed many, almost 140 operations or the 120 operations of double switch. And this is disease experience published in December 1 month ago. You see, survival of 10 years is 82%, 77% of so-called Rastelli sending operation. It's almost similar with classical repair. And during follow-up, 40% of patients had full ventricle function of morphology left ventricle. And the majority of patients double switch had mid-aortic incompetence. Many patients underwent aortic valve replacement. 75 interventions, including the catheter intervention and surgery, is almost 50%. And when Richard Jonas discussed this patient during the presentation, he said that there's some point of criticism that bad ventricular function is quite often. High incidence of the late need of reoperations, of almost 50%, valve regurgitation, and pulmonary artery problems. So question is still open. So I have no answer what is the best operation for the corrected transposition. And recently, Richard van Praag published an interesting paper titled, "What We Have Learned About the Transposition." And what I would say, what we have learned about the surgical experience transposition. I would say there is no ideal operation for different types of transposition of the great artery. We have several problems. Although the modern operation of transposition are curative because of their complexity, they be a potential various late complication. And so on. It's never logical we have to do the same operation for the next 20, 30, or 100 years. In the future, we have waiting for more novel procedures for transposition to ensure better results in mid and long-term mobility for our patients. Thank you very much for your attention.